My name is Randi Wright, and I am a DNP student at Arkansas State University, and the title of my project is HPV Immunization Intervention Application in Rural Arkansas. The project question is, in males and females age 11 to 18 currently residing in rural Arkansas, does implementation of an evidence-based HPV vaccination clinical intervention program compared with current clinical practice affect HPV vaccine uptake after 1 month of implementation? The aims of my study were to increase HPV vaccination rates, including initiation and completion of series in adolescents 11 to 18 years old in rural Arkansas, and to also increase healthcare provider and clinical staffs practicing in rural Arkansas's knowledge and communication with patients/parents regarding HPV vaccination. I did use descriptive analysis for this study, specifically chi-square test method. Data was exported from Excel to SPSS software, and then everything was numerically coded. These are the formulations that I used for the results of my study. This study was completed in a private rural health clinic in Northeast Arkansas, which provides care for over 7,000 patients, including 600 patients 11 to 18 years old that are eligible for vaccination. The staff includes 2 full-time nurse practitioners and 11 support staff, and then immunizations come from the VFC, SHIP programs, and then private immunizations. The population for the chart review included males and females 11 to 18 years old that had presented to the clinic during the allotted time frame, which was either 4 weeks prior to intervention or 4 weeks after intervention. 100 charts were pulled for both pre- and post-intervention. The survey population included all of the healthcare providers and support staff that worked within the rural health clinic. The instruments used included a survey, which was a validated tool developed by the Gillings School of Global Public Health at the University of North Carolina, Chapel Hill. It was provided pre- and post-intervention to clinic employees, where it was self-administered in a written format. The data collection tool was also used, which looked at gender, age, insurance status, HPV vaccine status, and up to date on other vaccines. The researcher was responsible for creation and application of the interventions and then the training, which included a 30-minute PowerPoint working lunch addressing HPV vaccination and language regarding the vaccine. The intervention bundle included 9 interventions. The interventions included the nurse being responsible for pulling all immunization records for patients prior to the clinic opening daily. All walk-in patients had to have the shot record pulled by the receptionist, and then the vaccine information statements had to be placed on the clipboards with the shot records. Nursing assistants made sure that the immunization record and the VISs were on every clipboard before getting patients back, and the VISs were given to the parents in the room. Nursing assistants had to make sure that the immunization records were placed outside of the room so that the healthcare provider could make sure they were acknowledged. Prior to entering the room, the healthcare provider had to make sure that if there wasn't a shot record on the clipboard, then they had to get it pulled. HPV reminder posters were placed in every patient exam room and in the waiting room. Every patient was scheduled to follow up on appointments for their 2nd or 3rd vaccines, and they were also giving a reminder magnet. An office assistant initiated reminder calls for those that were identified as missed opportunities on WebIZ, and the HPV immunization quality measure was implemented on the EMR system. The results of my study demonstrated that the training and emphasis placed on the HPV vaccine improved clinical staff's feelings about routinely recommending the vaccine. 100% of respondents would recommend the vaccine, and it was important to them post-intervention. Confidence also improved, with 100% feeling confident addressing the HPV vaccine post-intervention. I also found through my survey that the bundled interventions and training were very well accepted, with 100% of the respondents agreeing it fit into their workflow and that they would recommend it to their colleagues. The vaccination rates also were significantly improved, which was an aim of the study. The first injection rate increased 17%, second injection rate 21%, third injection rate 7%, and our series completion increased by 21%. HPV vaccine uptake was directly impacted by this multi-component approach. The results of the study demonstrated significant improvement in HPV vaccination implementation and in series completion, which was the whole aim of the study. The interventions and trainings were well accepted and easily implemented by the staff. And then we're going to see HPV vaccination rates continue to improve as the incidence of the missed opportunities continues to decrease within the clinic. My hope is that future studies are going to focus on utilization of the training and the interventions in other clinic sites.